Hi, good day everyone. Today I will be presenting on testicular torsion, a true urological emergency characterized by the twisting of the spermatic cord leading to ischemia of the testes. This condition requires rapid recognition and surgical intervention to preserve testicular viability. And I am your instructor, Dr. Muhammad Junaid Bajwa. So let's start the topic. Testicular torsion occurs when the spermatic cord twists, cutting off blood supply to the testes. It commonly affects neonates and adolescents, especially during puberty. Without timely intervention, the testes can become infarcted, resulting in infertility and testicular loss. The incidence of testicular torsion is approximately 1 per 4,000 males under 25 years of age. It exhibits two age peaks, one in neonates and another during puberty. There is no significant side predominance, though left sided torsion is slightly more frequent. The bell clapper deformity, where the tunica vaginalis envelops the testes and epididymis completely, allows excessive mobility, predisposing to torsion. Rapid growth during puberty and sudden cremasteric contractions can also trigger torsion. Occasionally, trauma or exposure to cold may precipitate this event. Pathophysiologically, testicular torsion leads to obstruction of venous return followed by arterial compromise. Ischemic changes begin within 4 to 6 hours, and irreversible necrosis can occur after 12 hours. Thus, the golden time for surgical detorsion is within the first 6 hours. Classification: testicular torsion can be classified as intravaginal, where the tunica vaginalis twists around the spermatic cord, common in older children and adolescents. Or second type is extravaginal, which is seen in neonates, where the tunica and cord twist together. The degree of torsion determines the rapidity of ischemia. The hallmark symptom is sudden severe unilateral scrotal pain, often accompanied by nausea and vomiting. On examination, the affected testis is tender, elevated, and may lie horizontally. The cremasteric reflex is typically absent, which is a key diagnostic clue. And there is high riding horizontal testes, which is also called as prehensile. Differential diagnosis includes epididymitis, torsion of testicular appendages, inguinal hernia, or other causes of acute scrotum like trauma or henochsicnolian purpura. Distinguishing torsion from epididymitis is critical as management differs drastically. Diagnosis is primarily clinical. Color Doppler ultrasonography can confirm reduced or absent testicular blood flow, but imaging should not delay surgery. In equivocal cases, immediate surgical exploration is preferred over delayed imaging. Treatment is surgical. Emergency scrotal exploration allows detorsion and fixation of both testes. If the testis is non viable, orchidectomy is performed. Manual detorsion may be attempted if surgery is delayed but should not replace definitive management. The prognosis depends on timing. Testicular salvage rates are excellent within first 6 hours but falls drastically after 12 hours. Delayed management increases the risk of infertility and psychological distress associated with testicular loss. Complications include ischemic necrosis and atrophy of the testes, infertility due to anti-sperm antibodies, and postoperative infection. Long-term follow-up may be required to monitor hormonal and reproductive function. Prevention primarily involves surgical fixation of both testes during the initial surgery, which is known as orchidopexy. Counseling should emphasize early recognition of symptoms and prompt medical attention, particularly in adolescents who may hesitate to report scrotal pain. So, to summarize, testicular torsion is a time sensitive urological emergency. Early diagnosis and surgical intervention within first 6 hours are essential for testicular salvage. Bilateral orchidopexy remains the standard preventive measure. So that's all for now. Thanks for learning with me. I will see you in next lesson. Take care till that time. Goodbye.